I'm very excited to introduce and welcome this morning Dr. Kristin Powell. She's from Florida, where she completed her medical school and residency at the University of South Florida in Tampa. She started her academic career at Albert Einstein College of Medicine in the Bronx before moving to the University of Colorado as a full-time academic OBGYN hospitalist. In her time at the University of Colorado, she has created a hospitalist section, and she serves as section chief of that section. She also started the OBGYN Hospitalist Fellowship, which is one of the first in the nation. She's passionate about quality improvement and patient safety, as well as medical education, and we're very lucky to have her here this morning to be able to present for us.
Thank you so much. I'm so excited to be here with you guys. I'm going to go ahead and share my screen here. Please let me know if you guys cannot see that. So again, yes, thank you so much for the opportunity to be here today. This is something that I'm really excited and passionate about, and I'm so excited to share with you guys today. I have no disclosures other than that I am just passionate about hospitalist medicine. And here are our objectives today. So we're going to outline the role of the OBGYN hospitalist in the current OBGYN practice, examine the contribution of the OBGYN hospitalist in reducing maternal morbidity and mortality, analyze some of the challenges to an academic hospitalist model, propose the future of OBGYN hospitalist medicine. And just because I can't be with you guys today, I do want to try to make it a little interactive. So I have a couple poll everywheres that we're going to do. So this is the link. You can also text Kristin Powell 713 to 37607, or you can just scan this QR code here. And I'll give you guys a moment to get your phone set up to do that. I think it's always a little bit more fun if we can be in some way or another interactive. And again, I'm super happy to answer questions at the end or put them in the chat as we go. So first question, I just want to know who is here in the audience today, who am I talking to? And that way I can make sure that I kind of cover all the bases. Perfect. So attendings, residents, and APPs mainly, some other non-healthcare people. And what is your experience with OB hospitalists? You've worked with them, you've heard of them, but not worked with them, or you've never heard of them. Good. So at least most people are familiar with, if not have actually worked with hospitalists. And last question, as we're getting started, what is your current clinical job? Great, another mix of everything, which I think is perfect. I'm excited to see residents or med students in training who are thinking of both general practice and subspecialty. So what is an OB hospitalist? This can be a little bit hard to define because hospitalists take many different roles depending on the hospital that they're at. My job, for instance, looks really different than a hospitalist who's in private practice or who's at a small rural hospital somewhere up in the Colorado mountains. But even though those clinical roles might look different, the goal of a hospitalist really generally looks along these lines. And so that's to be team lead during emergencies, take care of patients who are otherwise unassigned, be consultants to other services, act as MFM extenders, and really be the quality and safety experts on labor and delivery, and also just inpatient units that take care of women in the hospital. And so, as you mentioned earlier, you have some nocturnists, and I've heard hospitalists called a whole bunch of different names, laborists, nocturnists, and all of these terms are totally fine. But I'm going to tell you what the preferred terminology is from the Society of OB/GYN Hospitalists, and that really is just hospitalist. So, and that is, it kind of goes along with the campaign a couple of years ago. If you remember, I'm not just a generalist. Hospitalists really do so much more than just labor management or be in-house overnight. And so an OB hospitalist is someone who might staff the OB triage unit, labor and delivery, the antepartum unit, or the postpartum unit. Typically, an obstetric hospitalist has no gynecologic or gynecologic surgery responsibilities. An OB/GYN hospitalist include all the things that the OB hospitalist does, as well as covering the emergency department, emergent gynecologic surgeries, inpatient medical and critical care units, and consultative inpatient obstetric and gynecologic services. There are other names that I've heard. Also, for instance, in New York, they called their hospitalist safety officers, which, while I think that's a really weird term, and it took me a while to realize that that's what they were calling their hospitalists, it actually is also a good term. But I think it's just easier if we all use the same terminology when we're talking about it, because I think that kind of helps us move forward what we want to do with our hospitalist sections and subspecialty in the future. Hospitalists are kind of trending right now, and really we come in two different flavors. Hospitalists can want to be hospitalists because of the lifestyle. It's shift work. You can really kind of choose your own adventure in terms of whether you work at a really busy, high volume hospital, or whether you are just the backup who sleeps all night in a small hospital that delivers 300 babies a year in case the private provider from home can't make it in. And you really have a flexible schedule. And so that lifestyle appeals to a lot of people. And so there are hospitalists who choose it because of the lifestyle, or maybe they're at the end, but not quite ready to retire from their career yet. And they want to slow down a little bit. Then there are the hospitalists who are more like me, who really are drawn to the patient safety and the quality improvement aspect of the job. They really value the teamwork and the leadership that goes along with being a hospitalist. And not that you can't be one or the other, but I do kind of feel like we come in two different flavors. During the lecture today, I'm going to put up some slides that look a little bit like this. This is data that comes from the Society of OB/GYN Hospitalists. They put out a survey that's done about every 2 to 3 years, where they send a very long survey to all of their members and get the responses back. And it's really great because it kind of provides some data on who we are, what we're doing, what we're paid, what hours we're working, and what we would like to change about our job. And so I think this data is really interesting. And I think it also adds a little corroboration to my story that I'm telling you today. So on this slide, what I want to point out is that academics right now, we're only really making up about 11.3% of the total population of hospitalists. This has been increasing over the years, and I think we're going to continue to increase in the academic setting. But really, the hospitalist movement started in the private sector, and the academic side is really just starting to catch on. And we don't quite fit in academics the same way that we fit in a private setting. And so we're finding ways to make this role work for academics. It's fun, but it can also be a little bit challenging. So why do we have hospitalists in the first place? We all know the challenges of work-life balance. Medicine is increasingly volume-driven. There are new challenges with surgical numbers and credentialing. Patients are more forward and vocal with their desires, and there's increasing acuity of patients and the associated emergencies that happen with these patients. And so it's become a challenge to maintain knowledge and competence. And backing that up even more is the pressure of getting these numbers and training in the first place. And so I just learned, hot off the press, that there are new numbers for training upcoming, and that the numbers of minimally invasive hysterectomies required in total is decreasing. You used to have 70 total minimally invasive hysterectomies and at least 15 TBHs, 15 TLHs. Now they're just keeping it to the 15 of each. Ultimately, I believe that this is going to allow for space for tracking during residency, and that can be for better or for worse, depending on how you're looking at it. But it makes sense, just as we have surgical subspecialists in our field, that we would have counterparts who are specialists in the management of inpatient women's care. So when I think back to my residency, which was somewhere around this time, I actually had a faculty member who left my second or third year of residency, and she went off to be a hospitalist at one of our kind of outside local hospitals that would sometimes transfer patients to us. And I remember thinking, what is this job she's doing? This is really weird. I don't understand. Cut to about 3 years ago, I went to my first Society of OB/GYN Hospitalists annual clinical meeting, and up she comes to say hi. And I had totally forgotten that she had left to become a hospitalist until I saw her there. But that was really my first and only experience with hospitalist medicine until I went to New York. But the idea of the hospitalist started out back in 2003 when they defined what was a laborist. And this was an OB/GYN whose sole focus of practice was to manage the patient in labor. It was suggested that we develop an OB/GYN hospitalist model to decrease stress, improve physician well-being, increase the length of professional practice, and decrease burnout. Cut to about 2010, when the OB/GYN hospitalist medicine was formally recognized by ACOG. And ACOG said that it supports the continued development and study of the obstetric and gynecologic hospitalist model as one potential approach to improve patient safety and professional satisfaction across delivery settings. Providing a standardization of medical care has been shown to lead to improved outcomes, and OB/GYN hospitalists can serve as the driving force behind the implementation of these protocols in labor units. And in 2016, the Board of Directors of the Society of OB/GYN Hospitalists published the following definition of OB/GYN hospitalist. They said, OB/GYN hospitalists provide care for patients in labor and delivery, antepartum, postpartum, general emergency department, and obstetric emergency department with minimal outpatient and elective gynecologic surgical roles. So essentially what that led us to today is that we are moving forward with becoming a more certified subspecialty, kind of following in the path of MIGS and PAG. And there's data to support this. So OB/GYN hospitalists have been shown to add quality to institutions, mainly focused around obstetric care. We don't have a lot of data on the GYN side of things just yet. For instance, at our own institution, we have an NTSB rate, which for those of you who are not familiar with those letters, is the nulliparous term singleton vertex cesarean rate. This is a nationally tracked average. And the goal really should be less than 27%. Most places set their goal as something 24% or lower. And so when we implemented our hospitalist section, we actually dropped our rate down to about 18%. Now, currently, in the past 2 years, we've seen our rate creep back up above our target. But with the help of our quality people and our hospitalists who work on labor and delivery consistently, we've identified that we actually think this might be related to our elective 39-week inductions in the ARRIVE trial. Even though we were one of the test sites for the ARRIVE trial, it seems like we might actually be having an increased C-section rate secondary to these elective inductions. So we're going to investigate further. And that's the benefit of having a small group of providers who's dedicated and passionate about providing quality care on labor and delivery, is that you can problem solve these things. So next question, how much time would you like on labor and delivery? Great, so a mix of everything, and that's not surprising at all to me. So I just love this piece of art, by the way. The midwives and the birth attendants are in this artwork are shown as strong women. And just as back then, it's true now, it really does require a team to safely deliver babies. But there are a lot of people who do want to be on labor and delivery. Personally, I see my job as not possible without my generalist and MFM colleagues, because if there aren't people in the clinic, then I have no one to care for in the hospital. Hospitalists being on labor and delivery at night avoid clinic closures for post-call providers the next day, but L&D is a job satisfier for some people, not as we saw, not everybody wants to be on labor and delivery. And truth be told, I have a bit of a hard time with this. I totally get it. I clearly love labor and delivery, but it can make it really hard to make quality changes and and change our standards of care when you have providers who are only on labor and delivery 1 to 2 times per month, which depending on an institution might only be a couple dozen deliveries for a whole year. So in our current state of maternal mortality, the same logic that legitimizes MIGs could certainly apply here. Who's the best provider to do a TVH for a patient? The provider who does 4 or the provider who does 50 in a year? I really think that we need to get away from the idea that obstetrics is like riding a bike and that it's something that anyone can do once they've been taught. And I'm not at all suggesting that we take labor and delivery away from full scope generalists or subspecialized MFMs who can only be there a few times a year because of how schedules and clinics work. But I do think we need to stop looking at labor and delivery as the fun part of the job that anyone is entitled to, because we do have a serious problem in this country with maternal morbidity and mortality. And we need to make sure that we're staffing our units in the best way that we can, which to me would include hospitalists in some role or another. Not necessarily taking away from generalists or MFMs, but being the safety and culture leaders for our labor and deliveries. This can get tricky with fundings, schedules, volume. And so sometimes it definitely can feel like a turf war for sure. Again, though, this is pretty unique to academic medicine. This isn't something that happens in private practice. But job satisfaction is a real thing. And at least according to the survey and my experience, hospitalists tend to be pretty satisfied with their jobs. I think it's for a lot of reasons. It's the clinical practice, it's the lifestyle, it's the problem solving, it's the flexibility in the schedule. And I also definitely think that the recognition of work is true, probably for all of us. I know talking to my colleagues that we all have feelings of being burnt out and underappreciated in different ways and for different reasons. And I think labor and delivery in particular, and probably more in academic settings again than in private settings, can lead to a feeling of underappreciation. How many times do we perform a stat C-section or fix a massive hemorrhage, and then we cheerfully tell the patient that they have a beautiful baby before we quietly leave the room? As OBGYNs, we are experts in calmly handling situations, gently telling patients the risk, and consciously or unconsciously trying to our best to not take away from the joy of the day and the birth. And not that we need to have accolades for the work that we do, but more often than not, we kind of fade into the background and we carry the stress of that precarious situation out of the delivery room with us, leaving the happiness with the family. And I would be willing to bet that some of the hospitalists' lesson satisfaction with the recognition of their work is related a little bit to those turf wars and just trying to find a place that they belong. And I found in my academic career that teams function much better when they know the roles that each player plays. And since hospitalists are much newer, it's important to figure out how to define that role. So recently, the Society of OBGYN Hospitalists put out the list of core competencies of a hospitalist, which I think is going to help as our field continues to grow. And at first glance, this list might not look any different than what you would expect the knowledge and skills of both a generalist and an MFM on labor and delivery would be, or maybe even a fourth-year resident, to be honest. But this last column of competencies, I think, is really what sets hospitalists apart. OBGYN hospitalist medicine provides a system of care intended to improve outcomes for women and reduce maternal mortality by utilizing OBGYN providers who have chosen to focus their practice on inpatient hospital management, improving their abilities to manage obstetric emergencies, and committing to equitable standardization of care, collaboration, and leadership. And personally, this is what really drew me to being a hospitalist. I actually started out originally as a private practice. It only lasted 1 year. I realized very quickly how much I missed being in the academic setting, teaching and continuing to learn. But really, when I made that decision to leave the private practice, looking back, I already knew that my best days were related to the inpatient care of women. But yet I took an academic job and was up in New York for 4 years. And what I found was that as I practiced, the thing I loved most was the identification, analysis, and fixing of a problem, and that labor and delivery was a venue ripe with things to fix. And so I started to transition my clinical role to that of a hospitalist. And there were some hard life choices that went along with that to make, as a lot of people who choose subspecialties have to decide. I love doing TVHs, but I realized that I started to lose sleep with stress once they were booked, as my numbers began to dwindle for various reasons as they continued to increase their MIGS program. And I came to the realization that therefore I probably wasn't the best person to be doing those cases. And so I tried really hard to convince my former institution to start a hospitalist program, but ultimately the leadership got stuck on the idea that a provider on their faculty might not actually be working 5 days a week. This is another challenge of academic medicine. I tried really hard to make it work. I worked 4 days a week on labor and delivery and took full generalist call, which at the time was 6 calls a month, and I was exhausted. That was a really hard job. And ultimately, I made the choice to move to find a better fitting job, and I haven't looked back. But one of the things that surprised me most as I did transition into being a hospitalist is that I actually do have really great continuity in my job. This can come from both the continuity of patients between shifts. When I'm on a lot, I really get to know those antepartum patients. I know who actually contracts at night, who might just want someone to stop in and say hi because they're lonely. I also get to know the frequent flyers and the OB/ED, and that really makes it much better to provide quality care. But also I have continuity of projects and initiatives and the staff relationships that are so important to providing safe and quality care that my generalist and MFM colleagues just can't get with the limited number of shifts that they have on labor and delivery. And so why is this all important? It's because we have a really big problem with maternal mortality. And again, I know that we all know this right now, but I feel like we just have to say it as many times as we can because that's the only way we're going to get to the bottom of this. But the definition of maternal mortality is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and the site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from an accidental or incidental cause. The maternal mortality rate for 2020 was 23.8 deaths per 100,000 live births. And that's compared with a rate of 20.1 in 2019. Our US trend is absolutely abysmal. And here it is compared to Europe and Canada. Worldwide, the mortality rate is decreasing, but here in the US, it's been increasing. Why is this happening? We have gone over this, and unfortunately, we just don't have a really good, strong answer for this. So how do we make it better when we don't know what's happening? I really think it takes an all hands on deck sort of situation where we're all aware, cognizant, and doing our best to help prevent this from happening. But I really think that OB and OBGYN hospitalists are going to be a big part of this. Listed here are the leading causes of maternal mortality worldwide. It's really a humbling list because these are so common. And it's also humbling because we are not bad doctors. We always try our best. Our intentions are always good. But there's a big problem here that we just can't seem to get a good grasp on. And sometimes, despite doing our best, we have a really bad outcome. And this is those causes, again, just in kind of a pictorial version, because again, we can never look at this too much. There's also a noted stark difference in mortality rates between racial and ethnic groups. There's a tripled pregnancy mortality ratio for non-Hispanic Black patients. So again, non-Hispanic Black women had a 3.2 higher risk of maternal death compared to non-Hispanic white women. And there's a lot of conjecture about whether this is related to education level, marital status, when prenatal care was initiated, maternal age. And really, there are a lot of factors that go into this, but we have to acknowledge that biases are part of that too. And I recently watched the Hulu documentary Aftershock. I actually think it just came out last week, and it was really hard to watch for a whole bunch of reasons. Number one is because my former institution was Montefiore, and it was really hard to hear about a bad outcome that they had, knowing the place and the people that work there and the good that they do and how hard they try and the quality care that they provide. Number two, because it's really hard to hear people criticize our profession so unabashedly with limited to no knowledge or acknowledgement of the good that we can and do. And three, and probably most importantly, is because even though it's very hard to hear the criticism and bias in the documentary against obstetricians, the main premise of the documentary is real. We have a big maternal mortality problem, and it disproportionately affects Black women, and it is not okay. And so again, what does this have to do with hospitalists? First, I'm going to ask a question. When was the last time you implemented a major change to your service line? So this could be labor and delivery. This could be in your clinics. This could be in the GYN onc service line. Wherever it is that you spend most of your time, when was the last time you implemented a major change? Great. So we have a little bit of a tie here between the last 6 months, the last 2 years, and none. And I think that's pretty typical. So my next question would be, how hard is it, or would it be, to implement a major change to your service line? Great. So mostly hard, very hard, impossible kind of make up the majority here. Mostly easy. I'm glad to hear that, because I personally think that change is really hard to implement, especially in medicine. And so I really like to think about when COVID started. Everybody around the nation wasn't sure what to do. We were all afraid. We didn't know how contagious it was going to be. And after talking to some of our colleagues in New York, we decided to implement what we called the COVID team. And essentially, it was a team of 8 attending providers, who were hospitalists or generalists. And we basically took over the entire inpatient management of the hospital, because again, we weren't doing any elective surgeries. There weren't any, gyn-onc patients that were coming in for their debulkings. It was really labor and delivery was fully functioning, as I'm sure you all remember. And then emergencies, ectopics, torsions, bleeding, things that would come into the emergency room. But even then, it was pretty quiet. And so we formed this team of 8, and we covered all of the inpatient services. And we did this for about 9 weeks until we really got a hand on what was happening with COVID, how infectious it was, and kind of got a really good picture of what we were looking at. And part of our responsibility being on this team was that after board sign out, which occurs at 6 p.m. every night, we listened to board sign out, all 8 of us, and then we would stay on a Zoom call for about 15 to 20 minutes and kind of talk through what were the problems that we were experiencing that day, what were our current issues with PPE, what questions the nurses had about how we were handling certain situations, what our current visitor policy was. And essentially what this allowed us to do was immediately problem solve any issues that came up, and then make immediate implementation of any changes that we wanted to make, because the hospitalist or generalist who was covering the hospital that night would start immediately. And so we were able to really quickly make rapid changes. We had a small group who could make quick and rapid decisions, and we functioned really well. It was exhausting. We had good camaraderie, but what I really think about is that we were really able to make a difference and provide a leadership in a time that was really scary. When it ended after the 9 weeks that we did it, pretty much we got 2 days into the normal flow of things, where we had our generalists and MFMs who cover labor and delivery 1 to 2 times a month start working back into the schedule. And we found that pretty much immediately, all of the work that we had done kind of fell apart because people didn't know the system, they didn't know what was happening. And so when I think about that, I can't help but wonder that if we applied the same idea to maternal morbidity and mortality, what would happen? And really, this is ideally what hospitalists are, maybe in a slightly less intense way, but they're a group of thinkers and doers, and a consistent group on labor and delivery and inpatient care for women who can make change. And I think that's really important. So I'm going to tell you a little bit about our program at the University of Colorado, because I know you guys are just kind of starting yours. Ours started about 7 years ago. And to be honest, it didn't succeed at first. The way that it started was during a conference, two older gentlemen who were nearing retirement, so kind of that type 1 flavor of hospitalist, came up and offered to cover the labor deck for the university at night. And our chair thought about it, and she thought it would probably be a good idea, and she took them up on it. Unfortunately, academic hospitalists are a special subset of hospitalists, and not everyone fits. And so they didn't work out for educational and other reasons. And so about 4 years ago, they hired myself and 2 other hospitalists to come in who were more of that type 2 flavor of hospitalists. And since then, I would like to think that we have all contributed and really helped things grow from there. So our labor and delivery consists of an obstetric team, which is made up of generalists and residents, an MFM team who manages their antepartum service, and then also labors and delivers their patients during the daytime, Monday through Friday. We have 2 independently functioning midwifery groups, and we also have an independently functioning family medicine group. The pros of our labor and delivery are we are a large tertiary care center. We have patients flown into us from not just Colorado, but all of the surrounding states. And so there's always some sort of exciting patient to take care of and learn from. We do have quality staffing from techs to nurses to residents, although admittedly, we are feeling some of those staffing shortages and nursing shortages that everybody is feeling right now. We have a great director of labor and delivery. She happens to be a hospitalist and has done a really good job at really changing the safety culture of labor and delivery. She instituted the Just Culture case reviews and has really done a great job in terms of that, and is incredibly supportive and a great mentor in terms of how to be a great liaison between nursing staff and physicians. Some of the cons to our labor and delivery, the physical footprint is crazy. When they opened the labor and delivery, they actually had it on 2 different floors. They had like a low risk birth center upstairs and a more high risk labor and delivery downstairs. Thankfully, that only lasted about 1 month. When I started, they had already planned to change it. And so labor and delivery is now on 1 floor, but we have 3 operating rooms that are all in physically different spaces. One is upstairs in that old birth center, and the other 2 are on opposite ends of the labor and delivery floor. It's kind of crazy. We have OB anesthesia only during the daytime, which can be somewhat challenging at the night, especially considering that at night we do have decreased providers compared to what we do during the day. So we do about 3,400 deliveries per year, which I think is pretty small to average for what is considered a big academic center. And so what does that look like compared to the national data for who uses hospitalists? So this is the data in terms of what size hospital, how many deliveries are performed at the hospitals that the hospitalists work at. So we kind of fall right in here. But basically hospitals of all shapes and sizes are using hospitalists, which is great. And we really formed our section just over a year ago. It was great because it gives us some power over hiring. It really added some legitimacy to what was a well-functioning team. And getting to have a leader gives us purpose because as it is, we are part of the generalist division, but our mission is different than the generalists or PAG or MIGs who are also part of the generalist division. There are some financial implications to having hospitalists. And so there are certain institutions that do have a hospitalist division instead of a hospitalist section. To be honest, it benefits the generalist for us to be a part of their division financially. And that is where we will stay. At our institution, we consider full-time to be 12-hour shifts in 28 days. We have hybrids that we share with family planning and generalists and soon to be MFMs. Having some hybrid hospitalists is great for expertise outside of hospitalist medicine. It really allows us to have a wide perspective on patient care. It can be difficult challenge in terms of scheduling because clinic schedules and all of those things that we have to account for when we are making our schedule. And it also can lead to some divided passions. You're passionate about family planning, passionate about hospitalist medicine, where are you going to spend your time and do your project? Ideally, personally, I would like to have about 1 to 2 more fully dedicated hospitalist faculty for our section. And this compares pretty much on par with what the national data shows. So hospitalists tend to work about 40 hours a week. This is what our schedule looks like. And so you can see that we function a lot more along those nocturnist lines. So we cover the hospital Monday through Friday evenings, and then we cover the weekends as well. So what it shows is that the hospitalists cover the deck about 60% of the shifts, while generalists and MFM double cover about 40%. Our busiest nights are Thursday, Friday, and Saturday. And so we actually just added a second hospitalist to that Friday night to be in-house just because we are busy. We really discourage 24-hour shifts as hospitalists just because we are actively involved. We're teaching. We are the sole surgical provider in-house, except for those Friday nights now. And so it can get pretty intense. So we really don't want to have people who are fatigued. We want them to be able to really be involved and invested in the residents and the patients. And so we tend to discourage 24-hour calls. We do have someone who's at home for GYN call, except for that Friday night, we kind of took over those GYN responsibilities. And in terms of how long the shifts are, again, this is the national data, and it really shows kind of that as your volume increases, the length of the shift decreases. We currently fit right along here, but again, remember the people who are answering this are mostly private practice, so they're probably not quite as involved in the care of the patients or involved in any sort of education, which is a very different role than what I do. And there are lots of alternate forms of coverage. By and large, hospitalists, we're flexible people. And so we kind of cover what's needed. If you look here at this data, basically only about 9.3% of the hospitalists cover a combination of weekday nights and weekend shifts. And so essentially what that means is what I would expect and do expect as a hospitalist is that, if I'm the one who's kind of covering those shifts that aren't being covered by generalists, I'm spending my nights in the hospital, my weekends in the hospital. Sometimes you do have to give a little additional benefit, whether it's in the form of payment, a decreased schedule, or other perks to get some of those hospitalists in who want to work those shifts. We have recently added GYN coverage to our Friday night calls. And so as you can see, about 83% of hospitalists do cover some sort of GYN, whether it's ED or consultations, and about 63.5% do the emergency GYN surgeries. This is a concern because some hospitalists are concerned about losing their laparoscopy skills. That's something that they want to maintain. It can be hard to take a job that is an OB hospitalist job, not knowing whether or not you are going to maintain those skills if you want to take a different job in the future that's going to require those. And some other challenges of being an academic hospitalist. Lots of academic institutions have expectations for their faculty that might be different than what is expected in someone who's in private practice or who works for a staffing agency. So things like attending grand rounds, medical student teaching sessions, book or journal clubs. It can be challenging. Our grand rounds are on Wednesday mornings. And so either I have a hospitalist who's post-call or a hospitalist who is going to be on call that night, or it might be the same person who's in between calls. And if you're taking attendance, that can be a bit of a challenge. Granted, as COVID has come, these things being on Zoom has made it a lot easier because previously there were expectations that people would drive in drive home to maybe sleep or nap before they come in for their night shift, and then come back to the hospital again. The same thing can be said of having meetings. Most people want to schedule meetings Monday through Friday during the day. And then if you want to be part of those meetings, you might be working that night, you might be post-call, you might be, again, working over the weekend. So it's very easy to want to be a part of the meeting because it's important to you, but suddenly you find yourself in meetings all day, or meetings Monday through Friday, you take calls Saturday and Sunday, and you've gone a couple weeks without having a proper day off. The same thing can happen with emails. There's really nothing worse than waking up post-call to an email that needs to be addressed by the end of the business day. And so just keeping in mind for those who are not hospitalists, being cognizant that the hospitalist team schedule is different when requesting meetings or emails that need to be attended to. And for people who are hospitalists, I suggest being a good keeper of your own time. This is something personally that I'm working on. Hospitalist practice can also be very politically fraught. You might be asked to navigate tricky situations regarding tracings of other providers. You might be asked to step into an emergency on someone else's patient, or make a judgment call on what's safe practice in the moment. And all of this can happen while seemingly encroaching on the territory of generalists or MFMs. And so it's a position that requires a humble grace, but also a leader's presence, and making sure that everyone has the job satisfaction that they want, while also providing the safest and best patient care possible. And in the same vein as the satisfaction with recognition of the job comes getting support from leadership regarding things that are needed. So sometimes we can do too good of a job splitting ourselves into 3 different people and keeping bad outcomes at bay. But how do we get the higher ups to realize that you're constantly towing the line of safe versus unsafe practice when nothing bad has happened, at least not yet? The educational impact of hospitalists for us has been incredibly positive. Our hospitalists constantly win teaching awards. And I think that's partly because they're a dedicated provider to the residents at times of high volume and stress. And so we get to know the residents really well. But also, I think a lot of it is because residents today really want to know why we do things, not just how we do things. And the hospitalists really are natural leaders and educators to the residents and students, because that is kind of the basis of what we want to do. We want to know why we're doing the things we're doing on labor and delivery and in the inpatient acute GYN setting. We want to know the data. We want to make sure that we're providing the best and safest care. And I think that really speaks to the residents and learners. So let's talk about fellowships a little bit. Fellowships came about because of the requirement for experience due to the high acuity and the need to be a leader in these situations. And fellowship really is to provide a fast track. Previously, the staffing agencies and private practices would require about a 3 to 5 year experience and a passing of the oral boards before considering someone to be a hospitalist. And that's great. The experience was there, but it definitely led to an older workforce, and it was kind of missing out on some of the really passionate, excited people who were younger in their careers who would be a real asset to hospitalist medicine. And so fellowships were developed really to provide a fast track for that. There are challenges with numbers in residency. For instance, my residents last year graduated with 15 to 23 assisted deliveries at the time of graduation. I actually asked my residency program to send me my ACTME numbers, and I graduated with 50. My former institution, our residents would graduate with somewhere between 150 and 200 C-sections. I did 3 times that during my residency. And not saying that we know that numbers don't mean competence. There's a lot of studies that show that, but that experience, that repetition means something. And I would hesitate to put a new grad on our labor and delivery functioning as a hospitalist without having some sort of additional experience. And that is where the fellowships really can come into play. So the data shows that we are increasingly less years out of residency in terms of when we start our hospitalist career, which again, I think is great because we pick up on those young, energetic, passionate people who want to be hospitalists. Currently, we are on our 4th fellow. Our fellowship is not an ACGME fellowship. It is approved and sponsored by our local GME, but it is not currently an ACGME fellowship. Our fellows are hired as an instructor and receive a PGY5 salary. Not that this is the driving force behind it, but financially, this is actually a really good situation because the number of deliveries and surgeries that our fellows do, they pay for themselves at least twice over during their year. And so financially, it's actually a good situation as well. Our fellows function as a 0.4 FTE hospitalist, taking those labor and delivery night weekend calls and also helping with some of the GYN backup at home. When I designed our fellowship, I really designed it thinking of training someone who wants to be in academics. And honestly, I based it on some of the things that I felt like I struggled with in my career compared to my fellowship trained colleagues. So things like experience and formal education in research and how to do a good research project. So our fellows participate in the research boot camp with the other departmental fellows at University of Colorado. The University of Colorado puts on a great academic educator curriculum that is for residents and fellows. It's 3 weeks long, happens twice a year, and it really kind of goes through how to be an excellent academic educator, which I think is a great opportunity for them to be a part of, something that I just kind of had to figure out on my own as I went through my career. We also, through the University of Colorado, have a Quality and Patient Safety Fellow Series that the fellows can get a certificate at the end of their experience, certifying that they've gone through these courses and how to collect data, implement a project, and make change in the places that they work. They also receive CME funds to go to a conference throughout the year, and they complete a fellowship QI project. In the past, my fellows have done an implementation of a QI curriculum for the residents, a quality project investigating estimated blood loss versus quantitative blood loss on labor and delivery. And last year, we did the implementation of a Code Blue simulation curriculum for the residents. Their schedule was really based off the core curriculum. When I developed the fellowship, we didn't have those core competencies from the Society of OBGYN Hospitalists just yet. So I actually sat down and made a list of all the skills and things that I thought I needed and made me good at my job. And then I mapped them back to where the fellow would get those skills. And so this is the schedule that I came up with in terms of where they would spend their time. I really allow them to be very flexible in their scheduling. They might spend maybe 2 days on labor and delivery on 1 week, spend a night in the OBED and do ultrasound one morning. The only things that I instead of, as opposed to them being in blocks, which is kind of the traditional educational model. And I think that flexibility really allows them to kind of investigate and figure out what makes them passionate, where they can spend their time to really figure out what they want to do in terms of quality and patient safety. The only things that I really ask them to do in 1 week blocks are highlighted here in blue, the GYN and the antepartum services. Some of the challenges of the fellowship. It can be selling the idea to leadership. Thankfully, I came in at my interview day at University of Colorado and said that that was something that I would love to do. And a few months in, I was given the green light to do it. And so for me, that was, I felt very well supported and incredibly lucky that I had that opportunity. But I do know that at other institutions, talking with other people who are trying to start fellowships, just getting the leadership on board can be difficult. Recruitment right now is hard. As I showed, we are not a huge presence in academic medicine just yet. And there are a large portion of residents who have no idea that being a hospitalist is a career option. And so finding a group of people to apply can be really difficult. In my 4 fellows, have taken 2 internal candidates. And my last 2 years, I've recruited external candidates. But you honestly get a lot of people who are looking for reentry programs, who have trained elsewhere or have been out of practice for a while. And, that's really not the goal of what I want from my fellowship. And I think what the goal of the fellowship around the nation are. Funding can be an issue. Like I said, our fellow pays for themselves, but once the fellowships are ACGME approved, this might get a little more difficult because they're no longer going to be able to bill. And so funding more so for the future is definitely going to be a challenge. Getting administrative support for the leadership. Again, when it's not an ACGME approved fellowship, making sure that you have the appropriate leadership for the fellowship, that they have time to formally run the fellowship can be a challenge. And more recently, there's competition from the staffing agencies. I said previously that the staffing agencies would want 3 to 5 years of experience and board certification before they would consider an applicant. But more recently, they've been saying that they will hire people right out of residency and mentor them up to be hospitalists, which I have mixed feelings about. So what is the future of OBGYN hospitalists? We have recently, the Society of OBGYN Hospitalists developed a fellowship task force with the main purpose of getting our fellowships accredited. Once that happens, I think it will be only a matter of time until we get recognition as a formal subspecialty of OBGYN, which again, I think will add legitimacy to us in all sorts of ways. And I really think that we're going to be a big part of improving the maternal mortality rates. And so our conclusions today are that hospitalists are here to stay. And so figure out what that symbiotic relationship looks like at your institution. Hospitalists provide expertise in emergencies on labor and delivery and GYN, and how can you incorporate that to improve your outcomes? There's an increased presence of hospitalists in academic medicine, and early exposures of our learners might help them find their passion and calling in our new subspecialty. And hospitalist fellowships will have accreditation in the next few years. And after that, the workforce will likely look a little bit different, but be better trained. If you are interested in more information, the Society of OBGYN Hospitalists has their annual clinical meeting. It's honestly, from a medical standpoint, one of my favorites because the content is just so relevant, great for students and learners to go to for sure. And then they have their website, the Society of OBGYN Hospitalists.org. And I am happy to take any questions that you all have.
Great, thank you so much. I'll open it up to the audience, and any questions, feel free to unmute and go ahead and ask.
Well, I know that, hi, Luther Gaston, I'm one of the nocturnists, and I know we're interested in starting a hospitalist program here. One of the things I'm interested in, though, is more than just OBGYN. We're seeing a sicker patient than we saw 25 years ago. And so that, doing things like POCUS and, focused ultrasound. We did actually one with the medicine doctors on a septic shock patient last Thursday going into Friday, and you could see that she was volume contracted, and so that having some intensive care type training, we're seeing massive hemorrhage and things like that, and having also having women have a advocate in the ICU with them that knows somewhat about more details about their situation other than obstetrics and gynecology. So I think, we're looking at that, but I think what I have envisioned for a fellowship is going to be a little bit more detail in terms of medical knowledge, in addition to obstetrics.
I think that's a great point. And I do think that things like point of care ultrasound are definitely in the wheelhouse of a hospitalist. There's a great workshop about that at the Society of OBGYN Hospitalist annual clinical meeting. And it's actually, I think, the project that my fellow this year is going to choose as her project. But I think that spending time following those patients to the ICU is definitely in the wheelhouse of a hospitalist. And but as you said, we could be the advocates for those patients in those situations.
Hey, this is Kaylee, one of the third-year residents. I was just gonna kind of piggyback off of what Dr. Gaston was asking and talking about in terms of how you feel like your fellows feel, what their comfort level is in terms of like critical care medicine, just managing those really high risk, high acuity patients after the fellowship is completed.
So it's 1 year. And so, you know, it's pretty intense. I think the part of it, you know, we make sure that we're going over all the medical knowledge part of it. And I think that's very important. But I actually think what's most important is the experience and the leadership in taking care of those patients, which is something that the fellow really focuses on during the fellowship, because you can go home and you can read about the medical knowledge stuff. And I think that's absolutely important. But it's really the experience and being the person who's making those judgment calls in the room when somebody needs to go to the ICU and someone needs to go to the OR. And you get that experience as residents, but really focusing in a year where you are the person who is the lead in that room is kind of my goal for the fellowship, to send somebody out who's going to be confident and competent in those situations.
This is Joe. Sorry, I'm turning on my video. I have a question about you said that the fellows act as a 0.4 FTE hospitalist.
Mm-hmm.
So do they do like shifts without a hospitalist? Sorry.
Yeah, in the past they have. We as we are trying to increase ourselves to have double coverage on at night, we made the decision this year that we will have the fellow act as the second person in house. And so whether they take that GYN and backup acuity role, or whether they are the primary OB provider for the labor deck that night, we'll flip flop back and forth and make sure that she gets the experience of both. But we want to not take away their experience being the leader in the room, like I was just talking about, but we are using them to kind of help build up our double coverage this year.
Right. I would say, if you know, when you guys do get board certification, that may be an issue to think about, because they wouldn't be able to do that going forward. But if you got a few years to build it up, it seems like a good strategy. Thank you. I thoroughly enjoyed your talk.
Thank you.
Yeah, thank you for joining us this morning. I think we're kind of out of time here for grand rounds, but really appreciate your presentation and discussion. I think very well appreciated here. So thank you. And if anyone has any questions for you, is it okay for us to email you?
I can put my email in the chat right now, and please feel free to reach out.
Great.
Thank you.
Thank you so much.
Bye. Thanks.